Hi, everyone. Happy Thursday. Thanks for joining us today. My name is Katie Lindsay. I'm with United Properties, and I am on the NAIOP Developing Leaders Committee. We're excited for today's event. We have a panel set up. I won't waste a lot of time, but I do want to mention a few things. As you know, this webinar accounts for continuing education credits if you'd like them. So just make sure to watch out for 2 poll questions. They'll pop up on your screen. They're just easy yes or no questions, and you'll just need to respond, and then we'll get you that credit. And then also we will have about 10 minutes at the end for Q&A. So you can type your questions in the chat throughout the presentation, and then our moderator, Jeremy, will address them at the end or as he sees fit. So let's get started. I'd like to introduce Jeremy Jacobs, our moderator. Jeremy is the managing director at Colliers in Minneapolis, and Jeremy before that was a developer and developed several medical and healthcare projects. So welcome, Jeremy. I'll hand it over to you.
Yeah, thanks, Katie. Happy to be here. Let's go around and get an introduction briefly from each of our panelists. I'll start with Amy.
All right, thanks, Jeremy, and welcome everyone. My name is Amy Dauma, and I'm a design principal with HGA Architects and Engineers, which is a national architecture firm that is headquartered here in Minneapolis. For the past 20 years or so, I've led the planning and design of healthcare facilities around the country, including hospital campuses, clinics, and specialty facilities. And I'm also involved with the research arm of HGA. So I'll be touching on a research project that we've been conducting on the recent rise of telehealth and its impact on healthcare delivery and facility design.
Thanks, Amy. Good to have you. Andrew Twito.
All right. Hi, everybody. Andrew Twito, Director of Capital Markets at Ryan Companies. So I spend most of my time sourcing debt and equity for our development projects. And I'm on the healthcare national sector team. So I spend a lot of my time talking to investors and our joint venture partners and ultimate buyers that end up owning our healthcare assets. And I'm happy to be here. Thanks for having me.
Thank you, Andrew. We're going to move up. Jill.
Hi, good morning. I'm Jill Rasmussen. I'm a principal with Davis, and we are a full-service commercial real estate company focused solely on the healthcare industry.
Thank you, Jill. Louis.
Louis Juarez. I'm a real estate broker for Colliers. I'm a member of the Colliers National Healthcare Fellows Network and part of our national healthcare platform.
Thanks, Louis. And last but not least, Chantilly.
Morning, everyone. Chantilly Malabago. I lead Mortenson's healthcare development vertical. Mortenson, as some of you know, is an integrated real estate development and construction company. Before Mortenson, I was with Dignity Health in California and also with Optum Care prior to that, really focused on portfolio strategy, transactions, and capital management.
Great. Well, good to have everybody here. We've got a very rich discussion ahead of us today, but before we do that, I want to start with a prompt for our first CE question. And Reagan's going to help us with the poll. But first question is, have you ever used telemedicine? Please answer yes or no. And Reagan will ask you to show the results once everyone's answered. Interesting. 61% are saying no. We'll talk a little bit more about telemedicine as we move through our conversation today, but I want to first start with a conversation with Chantilly and Louis about the impact of COVID, which is a conversation a lot of people are wanting to have on the healthcare system. And Chantilly, first to you, from your perspective, you talked about being with Dignity, Systems, and Optum, and now Mortenson. Through that lens, how have you seen COVID impacting the healthcare industry, both short and long term at the national level?
Sure. I want to touch on 2 key areas first as it relates to how COVID is impacting the industry. And the first is financial impact. At the onset of the virus and some closures, health systems and other care organizations stopped elective surgeries and procedures. And so this and reduced outpatient volumes translated early on in the pandemic into significant revenue losses, with systems reporting anywhere between 40 to 60% in losses. Now, COVID has also impacted our local economies, which affects the healthcare industry. So as many previously commercially insureds, so those who may have received healthcare insurance from their employers, may, as a result of job losses, become uninsured. And this impacts revenue quality for the healthcare organization. And so the trajectory of the pandemic impact is also dependent on our economies and how they will recover. So in the meantime, and early on in the pandemic, we saw a number of health systems in the country quickly implement cost savings to offset revenue losses, ranging from staff reductions, furloughs, pausing capital, draws from reserves. And some of these strategies were employed not just to offset revenue losses, but really to prepare for the uncertainty and duration the pandemic will have as the race for vaccines continues and as effective treatments are discovered. I just want to mention as well that not all systems are impacted with the same gravity in terms of revenue loss. To note, the financial position of the organization pre-COVID will play a role in how the organization will survive this pandemic. So as a quick example, Kaiser Permanente, which is headquartered in California, shared early on that while they were impacted financially, the financial impact was less about revenue loss as it was about investment losses that we all experienced with the onset of the recession. And in Kaiser's case, because the organization is both a health plan and healthcare provider, it's well positioned to sustain itself during the pandemic. Now, I just want to touch on the second aspect, which is the accelerating changes in care delivery itself, which has been spurred by expansions in reimbursement by CMS. So that's the Centers for Medicare and Medicaid. So CMS, in response to the pandemic, quickly reorganized and expanded reimbursements for previous inpatient surgeries into outpatient settings so that they can accommodate for inpatient care for COVID cases, as well as expanding reimbursements for telemedicine to include care across state lines. Now, some in the industry are questioning whether these CMS changes will continue beyond the pandemic, particularly for telemedicine, which we'll cover here. But indicators are that CMS is going to make this permanent as rules are being laid out for 2021. And the customers that we're working with, along with some of our my former employers, they're saying that telemedicine is stay and that it's already become part of their care delivery strategy. So future thinking, long-term, what does this mean for the industry, healthcare industry in particular? It'll mean continued focus on care containment strategies, changes in care delivery and operations, a stratification of the market that'll likely result in partnerships, M&A activity, perhaps even the permanency of CMS reimbursements towards telemed and that outgoing shift or migration to outpatient care. So again, those that entered the pandemic well positioned financially, they're more likely to be better positioned to take advantage of new market opportunities, recapture lost revenues, and of course, expanding market share.
Wow, we could focus the next 50 minutes on just that. That's a lot of stuff, but really quite interesting. And Louis, I want to turn to you next to, there's a lot that Chantilly offered with respect to what's happening nationally as it's related to COVID. You have great visibility locally on what's happening with medical tenants, medical landlord systems. What's your perspective on how COVID has sort of uniquely impacted the landscape locally?
Well, locally, there's been a lot that's happened, and as Chantilly mentioned, those that were in very good position previous to COVID and structurally were able to kind of quickly adapt and probably deal with it a little bit better. And those who made some of the infrastructure investments for telemedicine and some of the other things that were put in place previous, we're in better position to react to the quickly changing dynamic of the current healthcare system. Locally, what you saw was kind of a switch and a shift on the clinical networks. Many of the clinical groups started doing respiratory-only clinics. So what you would see is early on, they would shut down most of their clinics. And only those, then they would get calls ahead of time saying, do you see these symptoms? If so, then we'll direct you to one of these respiratory-only clinics to deal with COVID. Other things that we saw were, if you're going to be tested, we would test you in the parking lots, or we would come out and check to see if you're even capable or able to come into a clinic, because they didn't want to spread the potential of a lot of unknowns, especially early, of COVID back into clinics. So then there was as Chantilly mentioned, the additional use of telemedicine. Nationally, the telemedicine usage prior to COVID was in the low single digits. And just over the last few months, a survey with the advisory board group came back and said usage was over 23%. So if you think of the number of cases nationally, that is a huge jump. And I know that that trend had followed suit locally as well. One of the larger healthcare systems partners has already had over 400,000 telemedicine visits in the last several months. That's 30% of their capacity. So locally, that has had a big shift. Groups like Fairview were able to quickly adapt with some long-term assets that they were originally trying to figure out what they were going to do with. Bethesda Hospital was a long-term rehabilitation hospital, and was very quickly turned into a COVID-only hospital, which is not an easy process to do, especially with ventilation and HVAC isolation, and making rooms that were designed for rehabilitation to be designed more to ICU units. And so very, very adaptable. I think that's one of the things that you've seen specifically in our market. And so I think they opened March 26th. So if you think back to that time frame when we were very early on in an unknown situation, Fairview was able to adapt into that very quick model and convert that. We've seen other larger systems do the same thing, whether that's converting wings of a hospital or specialty areas for COVID treatment. And as Chantilly mentioned earlier, it's a cash flow issue. So early on, we shut down elective surgeries. We try to drain the ICU, slow down inpatient usage in general back in March and April. But at the time, we didn't have a lot of utilization. So when we ended up with was a lot of empty hospitals, a lot of empty ICU units, and that's a large revenue generator. And if you think of what that cash flow timeline looks like, it takes between 60 and 120 days to see that reimbursement. So when you shut hospitals down, reimbursements for healthcare systems and individual patients, they're feeling that cash flow crunch right now. So even though we've come back out and we're seeing elective patients, it's unfortunate, but now we're seeing over 300 COVID hospitalizations. So we kind of shut the hospitals down and the ICUs down, we had nobody, and now we have over 300 inpatient hospitalizations. Now we're running back to steam. Luckily, we have a better understanding about how this virus transmits and isolating patients and doing better protocols for treatment. So we have a better way of treatment, and the death rates have come down. But what we saw early on has really made an impact, and it's affecting the cash flow of both systems and healthcare providers right now. And they hope to kind of get through it this fall when reimbursements start to come back as they came back online.
Thanks, Louis. Amy, I want to come to you. You know, you mentioned in your intro that you spend a lot of time, obviously, in the design world, and HGA lives a lot in the research space. Can you kind of share with us how what Chantilly and Louis have already talked about is showing up in the physical environment, and where you and HGA kind of think things may go from here?
Absolutely. So Tony, if you are able to share the first slide, that would be great. And so we started conducting a research project roughly when COVID started, because we were hearing that so many people were moving to a telehealth platform. And of course that has a big impact on us, folks who work on the design of space. And so we were concerned about where that might be going. And so we're hearing a lot of the same things. Certainly the move to telehealth was enabled by the changes in reimbursement that Chantilly talked about, as well as, and I'm just going to touch on this a little bit more, the licensure rules. So the ability to practice across states was also relaxed at the early period of COVID. And so that also encouraged adoption of telehealth for larger systems. So moving forward, what we're hearing is absolutely the same as what Chantilly was saying, that the reimbursement is going to stay. The licensure issue has started to pull back a little bit already. particularly in the South. And so there's a good chance that we're actually going to end up with a patchwork of licensure situations across states. So that will complicate things a little bit, but at the moment, everyone's pretty much fully on board with telehealth. And so you asked about the impact on space, and that is still very fluid. So initially, we were seeing up to 40% of primary care cases being handled by telehealth. As folks can get back into clinic spaces, we're seeing more people come back in and more of a balance. So that's not to say telehealth goes away at all, but people are really trying to figure out what is the right balance of the digital space versus the physical space. So overall, we think there will be some reduction between telehealth as well as workers working from home from healthcare systems, just like many of us do today. So there will probably be a big reduction in clinical space, and that will particularly hit behavioral health. They have really embraced telehealth. Primary care is another service line that will see a lot of use. Chronic care is using it a lot, and even some of the specialties. And I guess one other thing I'll just touch on coming out of the research is that, and I'll just touch on this at a very high level, but even before COVID, places like Walgreens, Walmart, CVS, and even some of the big tech industries were starting to get into the healthcare space and were starting to disrupt it a bit. And now that telehealth is such a big component of healthcare, it actually enables some of those folks to do more than they were able to before. And so, especially as you think of, telehealth largely deals with the least acute or the least complex patients. In some cases, those patients are being siphoned off of the volumes from traditional healthcare providers. And so there might even be a greater reduction of space than just by telehealth itself. So those are just some of the findings. We're wrapping up the research over the coming month, and so we'll have more definitive information at that point. And so, Jeremy, one of the things that I think you're asking that we speak to was how COVID in general also impacts the design of space. And so we'll start with long-term care and senior living. Certainly this is one of the areas that's been hit the hardest by COVID, as we all know. And so if we move to the next slide, you can see why that is for many facilities. Traditional facility layout for long-term care consists of shared rooms, shared toilets, even between those shared rooms. So you might have 4 people using the same bathroom. Not much common space, and certainly not a lot of space for the PPE, the personal protective equipment that is required now in order to stop the spread of COVID. So I'll touch on a couple of things that we're seeing with changes to design. If you go to the next slide. At the scale of the room, these are the sorts of changes that we're seeing prior to COVID, but some really have a benefit for stopping the spread of COVID as well. And so things like not sharing rooms, not sharing bathrooms, clearly that's of benefit, but also having more space to provide the PPE. So the front porch area at the front, that's really intended to provide a space for intimate interaction, something that's not out in the open with everyone. But we found that they work really well for PPE donning and doffing spaces as well, and limits the amount of contamination. And in addition, having larger rooms allows patients, if they need to dine within their own room. So there's a lot of ways, once you have this sort of model, that you can control the spread of the disease a little bit further. And then moving to the next slide, if we look at this more on the facility scale, this is what long-term care facilities that are being designed today are looking like. And it really wasn't driven by COVID. It was driven by the fact that research shows that residents do a lot better if they are only contained, to a small group of people. They can get disoriented and they can get frightened with large groups of people because of issues with degrading senses and those sorts of things. So over time, folks have been moving to models where we have more of what we call houses, where we have fewer rooms, and the dining and a lot of those activities actually happen within those houses. Well, you can see that by breaking up the floor plate, that actually enables one of these houses to be designated as a COVID space as well. And that's one of the things that the CDC is recommending, that you do find a place that is separatable, if you will, from the rest of the floor plan in order to put COVID patients or those who might be COVID positive in a place that does not put others at risk in the facility. So again, all of these design changes are really driven by things other than COVID, but we're finding that there's a lot of benefit to them related to containing COVID. So any questions about that before I move forward, Jeremy?
One quick question. For existing facilities, are you finding that there's a lot of work being done to kind of modernize air systems or any other parts of those facilities to make them kind of more COVID compatible?
Absolutely, and that was one of the first things that we saw when COVID, shut down the world as we knew it. A lot of our projects, the architectural components, were put on hold for a bit for all the reasons that you heard earlier, but our engineers were very busy going in and doing retrofits and seeing what could be done with upgrades to the systems. So a lot of that work has been done and was done very quickly after COVID started. But it's been a big component of adapting facilities to be safer for people and staff.
Mm-hmm. Thanks for that.
Sure.
I don't know if you have a slide for the hospital component of this, but it comes to mind hospitals and medical buildings in general have tried to integrate a sense of hospitality, a sense of arrival to their facilities. How are hospitals able to maintain that sense of welcoming and hospitality, and at the same time do social distancing and screening and all of those things?
Great, that is a great question. And yeah, we can move to the next section, which deals with the changes that we're seeing in hospital design. So, and of course, this covers hospitals, clinics, ambulatory surgery, so healthcare design in general, aside from long-term care. So if you move to the next slide, the question that you raise is a really good one. The first thing that we saw is concern about bed space, as folks have mentioned. And there were a number of ways to deal with this, but in a lot of cases, there hasn't been the need for the beds that people anticipated. And if there are needs, most of them, like Lewis said, have handled them internally within the existing footprint. But there are systems, like we actually designed a system early on in COVID called the StatMod system on the right, that can expand bed capacity if needed. However, there are not many hospitals that are really highly impacted by this, because only so many hospitals have the right staff and the right equipment to actually take care of COVID patients. So there's quite a few hospitals that do not see COVID patients at all. So this issue of bed capacity is really concentrated in the larger systems who have that sort of capacity in the first place. So what we have been seeing more of, and we can move to the next slide, is just what you're talking about, this issue of how do you get people into the building, how do you keep it welcoming and still keep it safe? And it was really a challenge at the beginning. Everyone put up large signs in their entryway saying, "Don't come in." And then a few months later, when they wanted to open, they said, "Oh no, come in, we're safe." So that's been a really tough message to try to overcome. And the reality is we're still in a little bit of an in-between zone. But I think this was mentioned earlier, the parking lot is now part of the care process. So not just for testing, but vaccinations sometimes happen there. We talked about telehealth. And so if you need blood draws, instead of going into the facility, some facilities are providing blood draws in the parking lot. So it's a really different and unusual sort of use of space, and maybe not something that works so well as we move into the winter, but it's something that we're seeing. And then there is a lot of restriction on who can come into facilities right now. So you come into the vestibule, a lot of folks have been expanding vestibules so that you can do testing, temperature testing, and talk about where folks have been recently, et cetera. right in the vestibule before they get into the building. And then if there's not enough space there, we're seeing some temporary installations in the lobby. As you get into the check-in area and waiting, certainly there's social distancing, spreading out the chairs so people are at least 6 feet apart, or there's partitions. And then at check-in, I'm sure all of you have seen this if you've gone to a facility, plexiglass is everywhere now. So I'm sure the plexiglass industry is really having a run on their products, but there's a lot more separation at check-in. So I would say the issue of making things safe has really been the focus. The question of making things welcoming is really a bit outstanding, and I'll talk about that a little bit more later in the presentation. If you move to the next slide, we'll just talk a little bit about what we're seeing in the treatment spaces and the staff work areas. Similar focus on safety in those areas. So treatment spaces, a lot more focus on the materials and making sure everything is cleanable. That was always a concern, but much more now. Staff work zones also socially distanced a bit more. How we integrate telehealth space into either the treatment areas or the work zones is really what we're working on right now. For years, the staff areas, and especially in clinics, were becoming more collaborative models where everyone sat together. Well, now that more people need to make phone calls for telehealth, how do you provide space for that? So that's one of the models we're seeing moving forward, is a number of ways to deal with that. And then, of course, a lot more emphasis on PPE storage and the donning and doffing spaces for it. And then to get back to your original question, if we move on to the next page, one of the big concerns with what we're seeing is that, this is just an example of a traditional hospital. So over time, they've accrued, larger spaces, and it works a little bit like a maze. Those of us who design it try to fight against that, but a lot of times that's what we're dealing with as an existing condition. And before COVID, the public, patients, family members who are typically a really important part of the care process had free reign, at least in the public spaces, to go where they needed to. And all the waiting rooms, all the departments were kind of spread out, and folks needed to navigate their way. But as COVID hit, there was a lot of concern about congestion, about getting too many people into the building, and having a lot of cross traffic that could result in spread of the virus. So moving to the next slide. We ended up with a situation where the patients could come in, but for the most part, family members cannot. And this has really been a big challenge because, as I said, family members are really part of the process. In some cases, they're listening, they're helping follow directions on behalf of the patient, and they're advocating for the patient. And besides this, now we have family members sitting outside, and if they're lucky enough to have vehicles, they're sitting in their vehicles for up to 2, 3, 4 hours, depending on what the issue is with the patient. And so what we're seeing going forward is that this is going to start to change, and it probably will shape healthcare design in a pretty radical way if the virus is not contained relatively soon. And so moving on to the next slide. We're speculating that there's going to be more of an emphasis on bringing care to the patient so that you don't have to navigate these sort of maze-like conditions, and that the care is actually brought to the public space, which limits the amount of congestion and cross-contamination and all of those things. And we don't see facilities going away from the big lobby spaces that we were talking about, but maybe there's a series of those so that there's still some screening and patients can get to certain areas, but at least folks who are waiting or the companions can wait in a relatively conditioned space as it becomes January in Minnesota. So that's one area where we see a lot of change going forward as construction begins to pick back up. So any other questions about that, Jeremy?
No, well, I've got tons of questions, but I see Jill and Andrew, and I want to get them as well. So hopefully we get to come back to some of this during our Q&A, Amy. A couple of things. I'd like to come to you next, Jill, about kind of your perspective with what's happening. You see the world through the lens of developer, owner, and more, frankly. So we'll talk about that. Then we'll ask our next CE question, and then we'll turn the conversation to capital and what's happening in the world of capital in the COVID environment. So Jill, you know, pull out your crystal ball for a moment and tell us, like, you know, of all the things Amy's talked about, a lot of design changes. Some of them I'm sure you were integrating into projects ahead. You probably made some adaptations to existing buildings. What do you see sticking? What do you see as being kind of a temporary adjustment?
Well, you know, interestingly enough, I think, you know, I can say that the off-campus medical office buildings have been kind of, you know, dealing with that same issue. We saw, you know, a lot of our tenant base asking for the ability to expand into the lobby and put up, you know, ropes and hand sanitizer and signs and mask boxes and things. And so, you know, to accommodate COVID, we allowed that to happen. But now that building tours can start up for prospective tenants, it's really hard, you know, to get into a building that's kind of closed off with signage and is it a COVID patient, is it not? So hopefully a lot of that is kind of temporary, but they really wanted to do the screening outside of their clinic. So it was in the lobby. And as Amy said, it was in the parking lot for drive-through screening. And so I think over time, you know, I think once there's a little bit of a separation of, you know, maybe that acute care versus just wellness and where that ends up, you know, we'll have a clear focus on that. So I think everything is still, even as Amy said, fluid and trying to understand what that looks like. And right now, I think as we look at maybe permanent changes, Physicians Realty Trust, that is a healthcare REIT, did a patient survey, and their stat was 76.5% of patients want an off-campus or off-hospital site healthcare experience. And so I think the trend of, you know, the wellness care will end up in off-campus buildings, and kind of that more acute care will end up in the hospital setting. So I think you'll see a little separation of that. And then I think from a square footage standpoint, I think with telemedicine, everybody's thinking that the clinics will be smaller. Are the lobbies empty? However, the clinics now are dealing with the social distancing issue. So in the design that we're doing today, we're actually seeing, you know, a bigger lobby or a sub lobby because they're having to deal with, you know, that the distance that they need. So I think there's this unknown yet of, you know, how is the space going to get utilized? I know we've been working with a surgery group out of state that actually has doubled the size of their waiting areas, you know, based on, just like Amy had shown, how is that care going to get delivered? How many people are coming in? How long is that patient going to be in the lobby versus in a sub-wait versus pre-op, post-op? And so the space has actually gotten bigger in the short term because of social distance and a lot of different issues. But, you know, when we look at the stats where they're going to think that, you know, we're going to have over 1 billion telehealth visits in 2020, you know, what do we need all that extra space for? So I think it depends on the specialty, but I think in the long term, you're going to see, you know, high acuity at hospitals, and you're going to see more wellness, really just in more of a convenient kind of community care location.
That's a good insight, Jill. I like that stat from PRT. I'm going to ask Reagan to help me here. We're going to move on to our next and final CE question. And the CE question is, do you think medical cap rates will increase over the next year due to COVID? Answer yes or no. Reagan, once we have our results, we'll show them. All right. So 50% of us say that they will not. Fortunately for us, we have two people here who actually know the answer. Andrew, I'm going to come to you. What's going to happen with medical cap rates over the next year?
Yeah, that was good timing for that question. I was glad to see I was in the majority. But, you know, obviously it's not as simple, of course, to say what's going to happen with cap rates. And also, I mean, nobody really knows what's going to happen over the next 12 months. But I think in the short term, I see kind of two things happening. For high quality, call it core healthcare assets. So this would be long-term leases, fully stabilized projects, health system credits, you know, above investment grade, or large systems that are just very established, very well capitalized. I've seen very little movement in cap rates for those kind of assets, and they still remain very aggressive. I think there's just a lot of the tailwinds in the medical space. It's a little bit, to me, similar to industrial. A lot of the trends that were happening that made industrial in demand is kind of exists in healthcare. So as we've talked about, the movement away from inpatient settings to outpatient, that's created demand for, you know, for clinics and for developed properties using developer capital. Just the demographics, you know, as people get older, they need more healthcare. And then now just a focus on wellness. I mean, we got to get through this part about, is it safe to go to the clinic? Should I be going in? Should I not be going in? But once people get past that, I think there's going to be a renewed focus on maintaining and being proactive about health. And I think the investors see that. I think that capital is still readily available on the equity side. I think debt is still readily available. So they see those trends and they like the space, and they're putting their money where their mouth is. So a lot of big portfolios have traded during COVID. You know, we're not post-COVID, but, you know, since March, portfolios have closed at very low cap rates. And everything that I'm hearing, whether you talk to brokers or buyers, is that there's still a lot of demand for that kind of core stuff. So now the other side of that is there's a lot of unknowns. So if there's any kind of value add component where there's, you know, there's some lease up that needs to happen, or there's short-term leases, you know, all this uncertainty around reimbursements and telemedicine and where do we need to be, I think that is playing out. So I think people are less aggressive on anything that's more opportunistic value add. And I think, you know, cap rates will reflect that. So
good perspective.
That's my prognostication. Yeah.
Yeah. Well, if 2020 has proven anything, we don't know what's going to happen tomorrow, much less next year.
Yeah. Call me tomorrow.
Right. Yeah, exactly. So, Jill, I want to come back to you, kind of wearing the hat of landlord and broker. You know, what have you seen happening in the space around abatement requests, rent concessions? We hear a lot about that on the retail side, certainly maybe less so in industrial, but how's that played out in the medical space?
Right. Well, so obviously with a, you know, healthcare pandemic, our whole tenant base was impacted. Every provider we talked to said COVID changed everything. So, and again, I think there was a lot of help and support. You know, there was $175 billion in, you know, federal stimulus, which can, you know, with PPP can be forgiven, or low interest loan, which I think helped a lot of groups. It helped a lot of dental groups, surgery groups, because dental was closed down completely. Elective surgery, you know, was prohibited. So there was a lot of help there for them, but, you know, is it enough? There were disaster grants. There were some Medicare advance payments. But we saw a lot of groups, once they kind of figured it out, you know, we're going to landlords asking for, you know, some type of rent abatement. And I'd be interested to see what Lou has to say too, but I didn't see any rent abatement. I saw rent deferral, and I saw anything from, you know, a landlord saying, I can't, I have to pay the mortgage and I have to pay the utility bills, so I can't, you have to go get PPP, to landlords saying, okay, how about, you know, 2 to 3 months, and whether it was net or gross, it depended on, you know, where that landlord, you know, was comfortable or could do or felt comfortable doing. And that was paid back requested to be paid back during the year 2020. If it was a REIT, they really needed to see that revenue in this year, or over a 12-month period of time. And so again, we didn't see abatement, we saw deferral. And then it was really the dental groups, the dental specialty and the surgery groups that, you know, really needed that assistance and help as they were completely shut down. And the ones that could do emergency procedures really couldn't, because they had to give their PPP equipment to the hospitals. And so they were, you know, really, they just had to shut down completely. And so I think, you know, from that standpoint, I think there was help and assistance. And then the providers that we are talking to now are saying that they are, you know, they had significant drop in revenues for 2 to 3 months, and then now are almost back to, you know, 85 to 90% pre-COVID. But what we need to wait for is that all the pent-up demand. I mean, if you had hip surgery scheduled in March, you didn't get it, you're not going to wait another year and a half. You're going to go when you feel like you need to go now. And so I think there's been a lot of pent-up demand. Will it continue through the year? And then what does that look like, you know, going into next year? And the good point though too is that we saw also probably 95 to 98%, and this tracks nationally. We saw this locally in rent collections. And so despite the issues with the stimulus and, you know, some landlord discussions on rent deferral, the groups were able to pay rent. It's just a strong, you know, asset class that, you know, you see good rent payment and good occupancy levels. And I think that again ratifies the MOB as a great asset class, as Andrew was talking about.
Good. Yeah, there on the retail side, there's this phenomenon, revenge shopping, which is kind of the pent-up demand and everyone's buying.
Right.
Unless you're Lululemon, and you know, people have been buying like crazy for months. Lou, I do want to take the lead from Jill, come back to you. You know, you see the world through system eyes sometimes, and anyone on this call who knows anything about healthcare knows Stark Law. How is maybe Stark Law itself impeded, you know, decision making, or how people work around Stark Law when it comes to deferrals on rent or concessions?
Yeah, so especially when it comes to the bigger systems. So if you think of a big healthcare system, they are obviously a tenant in a lot of different buildings, as Jill mentioned, with big REITs, but they're often also landlords. So they either master lease or they own buildings, typically on campuses, typically, you know, high value assets. And then they will sublease out, or they will have direct leases to either partner companies or referring partners. And Stark Law is a national law that basically has a lot of limitations on giving preferential rents or discounts so that you get potential referrals. So it's set up to kind of even the playing field, which then puts in a lot of legal restrictions and issues that you have to do any lease if you're kind of leasing out to someone who could refer patients to you. So what that comes up with is as a healthcare system, if you have tenants and you have got a group that's asking for either deferral or rebates or you know, rent payments kind of pushed out, what you have to do is start thinking about, okay, how does this affect how we're going to internally look? And I do know of some larger healthcare systems nationally that ask specifically, hey, we're not sure what's going to happen. One healthcare system said, we're not sure we're going to be able to make payments. And that was nationally. And so they went into other healthcare systems that they were tenants in and said, we're not sure we're going to make this payment. I do know some local healthcare independent groups that the day one, they came out and said, we're not sure where this is going to go. We got shut down. We want 6 months of either free rent or deferred. With just, you know, right out of the chute day one, and saying we need 6 months because we're not sure. I think what that shows is more along the line of where they were pre-COVID, how they were capitalized, how they were operationally, and that kind of usage kind of then goes in forward. Now, nationally, Chantilly might be able to give more details on this, but I know there was some loosening of some Stark rules that made it easier for groups in healthcare systems to specifically kind of come back around and say, yes, well, we'll defer this payment, we'll allow you to spread the payment out, or we'll add this onto the back end of your term. As Jill mentioned, some of the other developers and landlords that we've seen, a lot of it was, can we restructure this? So it's either a deferment of 2, 3, 4 months, and we'll make that payment back over the next year. We'll make it sometime spread out. We'll increase the rates after. Or what some groups did, they came back and just said, fine, we'll do a 2 or 3 year early renewal, and then we'll give you that as a credit. So we'll give you 2 or 3 months of free rent as the impetus for renewing early of 3, 4 years. And as a landlord, as a building owner, having that term is always helpful. So being able to work through with that cash flow issue early on, but to get that length of term is really, really helpful. And so that can go back from both systems and from landlords. Kind of saw that as a blend.
Good. Well, if we were playing Hollywood Square, Circle would get the square there, Lewis. Andrew, coming back to you, and Jill, frankly, and kind of closing, and we want to open it up to questions. And what's happening around trades right now? Is product still moving? Have you closed on any debt or any deals recently? And if so, have they looked materially different or unexpected twists and turns? Andrew, why don't you take it?
Sure. Yeah, a couple just quick data points. We recapitalized an asset here in the Twin Cities. It was under contract pre-COVID, and we actually closed. I think we closed like March 14th. So it was like I was still in the office, and the guy from DC was like, "Hey man, like we got to get this done. I don't think I'm going to be in the office Monday." I'm like, "Okay, whatever, dude." And we closed. And we were glad we did. We got a great interest rate. We did a 5-year fixed rate deal with a local bank, and we did an interest rate swap, and it was a screaming deal because rates, Wall Street is smart. They knew this already. Swap rates were down and the spread was pretty low. So we were like high-fiving, and that was great. But I think, and I don't think much has really changed. I think that there are banks willing to do those deals. So my other data points are on construction loans, because we started construction on a surgery center in Asheville, North Carolina, and we're going to be closing soon. We just closed on a behavioral health deal. We'll be closing soon on a clinic in Chicago, and there's plenty of debt available for construction loans. A lot of banks are willing to leverage is still 80-85% loan to cost, if that's what you want. Interest rates are still great. There's interest rate floors. So, there's a floor on LIBOR of 50 to 100 basis points, plus your spread. But you only need to call 1 or 2 banks to get those deals done. I do think for longer term, non-recourse fixed rate stuff, the CMBS was out for a while. Life insurance companies were out for a while. I think a lot of that has come back to some extent. So that's been good. So I do think there's debt available, but I'll curious to hear what Jill has to say on that too.
Yeah, I would definitely agree with that. I think it's, the first part of the year, I think everything, since March slowed down. Lenders were having a hard time, underwriting and even quoting for a while, but I think there's still big demand. With debt capital being back, we're at below 4% interest rates. And I think there was a thought that, the sales volume in the second quarter was going to be really, really low. I just saw yesterday a stat that there were $2 billion in second quarter sales, which is much better than expected. It's not as high as it's been, but certainly trades happened. I think the issue still is we need supply. There's so much demand and there just isn't really good supply at any point in time that's available, whether it's an individual medical office building asset, or a bigger portfolio sale. And interestingly enough, one issue we had a property out of state under contract. We're hoping to close in probably April or May. With the interest rate drop, the prepayment penalty for the seller increased significantly to the point where they said, you know, we can't do this, we can't sell the building unless you guys, you know, take on, you know, or increase the sale price or whatever it might be. And, you know, we said, you know, we can't do that. It sat for a little bit and, you know, we're kind of waiting and waiting and waiting. And now the seller's got it figured out and has come back to the table and said, okay, I got to take care of my loan. I'll do that. And because I want to sell the building. So that was really interesting to see, you know, the interest rate drop significantly impact that prepayment penalty, and you're just stalled amongst everything else as well. But right now we've got 8 buildings under contract. We are hoping to close in November. We're working through financing at this point in time, and you know, cap rates are still low. I think there's still demand. So I think it's all, what I'm hearing even nationally is everything is moving in the right direction. It's back. You know, the investment market is back for medical office. It is just such a sought after asset class that I think we're finally, you know, moving forward. And now that debt capital is back, where everybody's trying to move everything forward.
Yeah, good. Reagan and Tony, I don't see any questions in, so I'll just keep going. And if there are questions, I'll look in the chat, or if people have, I don't know if they can talk, but we certainly welcome the questions. But Chantilly, I want to come back to you. You've had, you know, kind of a diverse and interesting healthcare experience. If you were a system today, and you're thinking, you know, what can we do to be resilient 5 years from now? Should they hunker down? Should they aggressively expand? Kind of what's the best advice we could give a system right now to position for the future and increase their market share?
Sure. Crystal ball and advice, I would say, number one, rationalize your business services. You know, look for redundancies within your portfolio. Healthcare ultimately is an ecosystem of care, right? And so look for those redundancies within your portfolio, examine what service lines are underperforming. Maybe look to either, you know, reduce that service line or even eliminate the service line. Think about how to redirect it within your portfolio appropriately. You know, what gaps in services are there in the marketplace? How can you take a look at how these service lines are being utilized within your built environment and find ways to truly optimize your footprint? Find ways to consolidate, to make strategic investments in assets out in communities that are accretive to your objectives in order to capture market share. And think about your healthcare ecosystem in terms of what's happening on campus. You know, the shift has happened, you know, the shift from inpatient to outpatient has already been happening pre-COVID, and that's just going to continue to migrate into our communities. And so think about how the future of healthcare on campus, and we heard, you know, Amy talk about this earlier in discussion, where most of the critical care is going to happen on campus. And we'll start seeing more of that, you know, ambulatory surgery care start happening in the communities, along with multi-specialties that, you know, will follow thereafter.
Good. Amy, kind of come to you with the same question. What's the best advice we can give a healthcare user today to position for the future?
Sure. Well, I think Chantilly gave a great answer, so I don't know that I have a lot to add, but I do think one of the things that we've seen that is positive is, you know, healthcare systems haven't always operated as systems. A lot of them have accrued over time, and there's smaller facilities in, you know, maybe more rural areas, and they're trying to keep all services in all locations. And I think Chantilly touched on this. We're seeing a lot more focus on system-wide thinking, which is great. You know, it's well overdue for healthcare systems, and COVID drove that in part because of finances, but it drove it in part because of things like PPE. You know, how do you distribute PPE to all of these different places and have a central location to store it and track it? So I think I would say continue going with that positive trend where you start thinking of yourself more as a system, the ecosystem that Chantilly talked about, and really start to, optimize, I think is one of the words she said, but really, streamline a little bit, and both in the physical footprint and in operations.
Good. Thanks, Amy. I've got a question that came in that I want to direct to Andrew, and I'll just read it. It says, we touched on debt in the market. Curious what the panelists are seeing from the equity markets and partners, both for acquisitions and development. Are they still as active? Have they backed off or slowed down? Has this been changing over the past, plus or minus 5 months?
No change. Those guys are hungry for, guys and girls are hungry for deals. To Jill's point, there's not nearly enough supply for all the private equity companies, the Harrison Streets, MBREs of the world, the REIT, Stock REIT, Welltower, the big private equity funds, Hamas. I mean, these guys have so much money for medical. It's not really, it is kind of funny, but they're still aggressive, and they're looking for opportunities. So they want to put money into development deals. They want to buy stabilized deals. If systems need to free up capital and they're willing to do a sale leaseback, they're there, they're ready. Let's figure it out. We'll let physicians invest in the asset. It's a pain in the neck, but we're willing to do it. I mean, there is a lot of demand, and to Jill's point, they're still willing to accept 5% cap rate returns, and the debt helps that a bit. But if cap rates were kind of low fives for core medical deals, it's still kind of pretty close in there, and the bigger the deal, the better. So the people that have been able to aggregate and put together a lot of smaller buildings, I think, are still seeing a portfolio premium. So no change as far as I'm concerned. Frankly, I could continue this for a long time. It's been really fun and a lot of good stuff, but we're at an hour. I wanted to thank Katie and Tony and Reagan for helping us set this up. Our panelists, Louis, Amy, Jill, Chantilly, Andrew, terrific perspective, and the DLs for making it all possible. So thanks, everybody. Enjoy the day.
Thanks, Jeremy.
Thanks, Jeremy.
Goodbye.